Good morning. Welcome to another episode of the Jaw Complex with myself, Dr. Jaffari, and
Oh, Dr. Newaz.
today we're going to be going over some frequently asked questions that a lot of our patients have. And so, let's get started.
Very good. All right. Well, I guess let's go ahead and do one frequently asked questions. Compared to other options out there, why is skeletal expansion a better option, right? So I think this question depends on understanding your patient, understanding their goals, understanding their age, and other, bone density factors. Skeletal expansion, is our, of course, almost universal choice for adults. Adults need bone anchorage, right? So basically, for children, the whole premise of pallet expansion, right? The concept of a pallet expander, it's an inside brace that has a little mechanism, whether it's a jack screw or a spring or, something, that basically, when activated, pushes the back teeth against the walls of the bone in which the teeth are sitting. And then the bone connection between the right and left halves of the palate is otherwise loose or pliable enough to create expansion at the roof of the mouth. So that is a great concept that works for immature sutures, right? For children and teenagers. And, of course, within the teenage bracket, there's some, of course, continuum of suture pliability. And depending on the needs of a teenager, getting expansion, of course, if we want to just get some, dental arch width and understanding our patient, we have reason to believe that skeletal maturation is relatively, low, that a tooth corn expander should be just fine. And then if skeletal maturation is high, or if we have increased bone thickness, increased bone density, or we have a little bit more of a reason to be intentional with improving nasal gains, or if we have a class 3 or underbite patient that might need bone anchor protraction beyond maybe the age of 10 and a half, then bone anchored expansion is a really good tool to promote, of course, both the expansion and protraction. Of course, forward traction of the maxilla or the top jaw is something that becomes possible when we separate the sutures of the midface, right? That includes the mid-palatal sutures and other circummaxillary sutures, basically a fancy way of saying different sutures, around the top jaw or the maxilla, higher up or further back. And basically the whole premise for protraction or applying tension to distend the midface forward is that basically the sutures are separated through expansion meeting. And so essentially when we want more of that effect for whatever reason, bone anchored expansion tends to be a good thing unless your patient is relatively young. I think under 9-10 years old, you could probably pretty reliably do that with a tooth borne appliance. And perhaps over that age, bone anchors should probably be considered to skeletally address underbites.
There are other expanders that have utilized for adults, especially tooth-borne expansion. That could be the AGA or the DNA appliance. AGA was a popular option about 5 to 10 years ago. We do not do that. We do not subscribe to that because essentially you're pushing the teeth, especially AGA with its forces and quick forces. You're damaging the teeth, you're damaging the alveolar bone, and causing the risk of significant tooth and bone loss. There is also the DNA appliance, which works a lot slower, and we, once again, do not subscribe to that concept and theory of a bone being developed around the alveolus. And so we, once again, subscribe to the option of skeletal expansion.
So when would palatal expansion not be a good idea? Would everyone benefit from it? And who is a prime candidate for palate expansion? So, essentially, palate expansion might not be a great idea if you have certain facial characteristics. If you're already pretty wide in the midface, you have a very robust midfacial bone complex, a lot of cheekbone prominence, and so forth. And you might consider not doing palate expansion if you're also very, relatively well developed in the maxilla. You don't also have any particular indication to expand that nasomaxillary complex. One of the things that I tell patients is that, one of the primary indications for me to deem somebody a good candidate for palate expansion as an adult is essentially having, some sort of nasal resistance or trouble breathing through the nose, or if those two conditions are not the case, if we see anatomic constriction of the nose and it would otherwise help for tooth uncrowding purposes, fixing something like a crossbite, or, if it would otherwise be, of some utility in just putting the occlusion together in general, or giving the lower jaw a little bit more clearance, for purposes of, positioning it neuromuscularly in a neutral position. So palate expansion, it is an additional procedure. That procedure does have risks. If somebody simply doesn't need it based on how they present, then we generally don't recommend it, or we may recommend it only if there is some particular objective, that the patient has to broaden or widen the smile, and then we see if it's appropriate otherwise to pursue palate expansion as a means to do that, because sometimes we can get pretty decent, modest widening of the smile with just general orthodontic means, right? Braces or Invisalign. So not everybody would benefit from palate expansion. I think a lot of people, who have some sort of underdevelopment of the jaws might benefit from it. Essentially a prime candidate for palate expansion is somebody with, a lot of crowding, a lot of a confinement of the bite that otherwise doesn't allow the lower to also uncrowd or, sit in a decompressed position. Or of course, somebody with a upper airway or breathing related issue, or anatomic nasal resistance.
Another circumstance where a patient would not be a good idea is medical reasons, where they have a bleeding disorder or some type of bone disorder, where they're taking medication like osteoporosis, where bone turnover would be impacted, and the healing process, obviously without bleeding as well. So usually those would be some of the medical conditions that would preclude us. It is
for adult surgical,
correct. A placement of the actual expander with blood, and then with a bone, the overall healing process and the bone consolidation is clearly impacted with medications and symptoms and a problem like osteoporosis. Also, another prime candidate would be somebody that has a narrow palate, and with that restricted tongue space and confined tongue space. Some people have larger tongues, and their tongue is basically caged in by their teeth and arches. So that could be another candidate. Sometimes we see patients that have larger tongues that sometimes their ENTs or different surgeons may recommend resecting a portion of their tongue that's significantly harder and more complex, in our opinion, of a surgery with a less predictable outcomes, in our opinion. Right. Thoughts on premolar or molar extraction, how they can impact the airway? Does it differ for wisdom teeth? We're clearly anti-extraction dentists and orthodontists over here. So we have both have gone through extractive and premolar therapy, which we suffer from in terms of, that's why Dr. Wise currently is FME, and I plan to get an expander in the next year. But we do not recommend premolar extractions. We don't condone it. We definitely don't do it. And we oftentimes reverse that for our patients by expansion. How does that impact the airway? Uh, some of the thoughts behind the impact of it on the airway is that it shrinks the palate, which shrinks the floor of the nose as well. Also constricts the arch for tongue posture. And then for wisdom teeth, we believe that the wisdom teeth actually, their presence keeps the bone more dense and the arch in the back a little bit wider. It's also visible as we age. That keeps the bone a little sturdier. So that's kind of my thoughts on that. Otherwise,
Yeah, I think, and just to get a bit more granular about that answer, of course, in the absence of surgery or decompensation for surgery, basically, we do not order the extraction of premolars for any case. And so there's sometimes an indication to do it for a surgical case to decompensate incisors to promote better bone positioning. Of course, if you are able to get more dental retraction, you might be able to get more skeletal protraction. So that is the one, that's the one case where, of course, the net gain that you're going to get from, just the temporary, sort of constriction of having, premolars taken out, before surgery. Of course, the whole purpose of that is to promote a much more, robust surgical movement forward. Like lower premolar extraction is a very common thing to maximize mandibular advancement surgery. And
so you'll go back one step to move forward 2 or 3 steps.
Absolutely. And then for wisdom teeth, I think it's important to make the distinction that, generally, wisdom teeth are generally, I think, airway neutral, meaning, I think a very, very, very vast majority of people who get wisdom teeth out, especially in cases where there's insufficient space for wisdom teeth, do not end up with an airway problem. It's very important for, we don't want our answer to this question to make people who have had wisdom teeth extractions to go into a worry or panic that may have somehow compromised their airway. In a very, very vast majority of cases, they do not. There are some, there is a very small minority of people who, again, we listen to our patients. We see that there are some patients that will come to us saying that they feel some sort of changes with their breathing or their bites and things like that. And the two not being uncoupled, really, they feel that those things might, essentially contribute to each other in some capacity. We give credence to that experience from the patient. And we tend to see, of course, more of those types of patients that may, of course, your average patient who's gotten their wisdom teeth out will not necessarily have or ever develop a problem. But for those maybe 1 or 2% that do, we tend to see them, we tend to hear them out. And we think that there is maybe perhaps some basis for it. Of course, there are things that can happen in the surgical process that might, perhaps, render, those areas prone to, some sort of hard and soft tissue changes where, essentially the presence of those teeth were giving some sort of support to the bone housing them. And usually the results in atrophy, again, is no big deal. But maybe in some cases, we've seen cases where people feel that their jaw position, their facial, appearance has changed after wisdom teeth extraction. And then there are even some reports in sort of the notes and pranings of the literature about, pharyngeal constrictor muscles, being affected by wisdom teeth extraction. And that is, again, that's a very sort of, what we would probably consider a rare occurrence, but nonetheless possible. So it's important. That's why my personal, default answer for people seeking an opinion on whether they should get the wisdom teeth extracted is A, of course, consult the oral surgeon, but B, in the absence of a problem, there's probably not as much of an indication to get it out as perhaps some of the recommendations that they may be getting otherwise, right? Because if they're not causing a problem, nor are they causing a susceptibility to having another problem. And what is susceptibility? I think that's where, it's a very nuanced discussion, right? Some dentists and oral surgeons will basically say any sort of impaction is susceptibility for developing pathology, developing a problem with the second molar, developing a problem with cavities on the back of the second molar, or developing pericoronitis, or basically inflammation of the gum tissue, perhaps partially surrounding a partially erupted wisdom tooth. So we see that in those cases, that sure, there are certain cases where if you have infection, you have susceptibility of infection, you have caries on the wisdom tooth, or you have, caries on the tooth in front of it, caries meaning cavity or dental decay. If you have any of those conditions, then that may be a situation where you may want to more strongly consider wisdom teeth extraction. So we don't want to be too polarizing with our answer here regarding wisdom teeth. There certainly are dental indications for taking out wisdom teeth, and we acknowledge those things. But there are a lot of cases, especially we find in the West and the United States, where wisdom teeth are taken out absolutely unnecessarily, and we don't subscribe to that practice.
Now, follow-up question. We do have patients that actually seek us out for placing possible implants at wisdom teeth. That's very rare. Once again, based off what Dr. Newaz said, there may be some airway impact, but that's not definitive in the literature. But as a implantologist, it's extremely difficult to place implants that near the inferior alveolar nerve. There's a lot of risk, a lot of vital structures over there. In addition, it's actually very challenging dentally to surgically place an implant in that area due to the size of the drills and drill bits and the size of the implant. Usually we tend to shy away from that due to the risk and the difficulty of the procedure, followed by its success. So if, God forbid, there is an issue, it could be significant with additional bone loss. So it may not be worthwhile to place an implant at a wisdom tooth extraction area, let alone it being where the wisdom tooth already was taken out, usually less bone anyways, of dental alveolar bone for an implant.
And we will usually offer some sort of alternative solution. There are, if there is a need for additional dental units, to be added to the patient's mouth, there are ways, and, why would there be a need? Let's say otherwise in the expansion / orthodontic process, we're creating space and perhaps protracting all the back teeth into the space would be an orthodontically arduous thing to do. Then there are indications for, maybe we leave a little bit of space open for, maybe like a third premolar or first mini molar, right? Let's say somebody has the first and second molars, they have the two premolars, and perhaps, instead of course, just putting the implant where the wisdom tooth was, you could kind of distalize or move the existing molars back a little bit. You could, of course, consolidate space that results from our expansive efforts, anteriorly, in a forward direction there, and we can consolidate the resultant space to that sort of third premolar area. And sometimes it, does facilitate not having to then protract the molars, which again is orthodontically sometimes a little bit of a challenging proposition because it adds time, it adds risk, it adds, and of course, sometimes there is we can show an infographic here as I'm explaining this answer, but there is, the dental arch, has wider bone buccolingually, or from the outside to the inside, from the cheek side to the tongue side in the molar region, and then it sort of tapers as you go forward. So if you are taking teeth that belong in that wider part, and then you try to force it into a little bit of the narrow part, sometimes that is impractical. So it's better to kind of keep teeth closer to their native positions, and perhaps add additional teeth or implants where you have less anatomic susceptibilities like neurovascular structures, right? Mental foramen, inferior alveolar canal or mandibular canal, and in the case of the maxilla, the sinus, right? And the maxillary sinuses, can descend or pneumatize into the alveolar process that houses the bone, or that houses the teeth in the posterior maxilla. So there are parts of the posterior maxilla where perhaps the bone height before you get to the sinuses is a bit more favorable, and it's usually not in the molar area.
Hey guys, thanks for watching. Put your comments with questions and we'll feature them in our FAQs. Make sure to like and subscribe and look out for our new video next week.